Imagine spending maybe 6 hours on an operating table.
Yeah, and taking 6 weeks off work.
Right. Enduring weeks of painful recovery, and then only to completely destroy the surgeon's intricate work just because you, well, sneezed.
It sounds wild, but it happens.
It really does. So, welcome to this deep dive. Today we're looking at your internal engineering. Specifically, we're looking at a scenario that sounds completely absurd on the surface. Like, can something as simple and seemingly unrelated as a cough completely derail your recovery from a pelvic treatment or surgery?
Because usually, when we think about fixing a problem in the body, we picture a very isolated process.
Right, like patching a bicycle tire or something. You find the hole, apply the patch, let the glue dry, and you're good to go.
Exactly. But what you don't do is immediately hook that newly patched tire up to a high-powered industrial air compressor and just blast it.
No, of course not.
Right, because if you do that, the patch doesn't just fail, it blows out violently. And, well, we do this to our bodies all the time because we tend to compartmentalize our biology.
I mean, we think the plumbing down below is completely separate from the ventilation system up top.
We really do.
But the moment you start digging into the sources we have today, that illusion just completely falls apart. To get to the bottom of this mechanical mystery, we're unpacking a really fascinating stack of material for you today.
It's a great stack.
Yeah, we've got clinical FAQs from the Women's Health Clinic, we have detailed patient recovery guidelines from the NHS, and some deeply revealing physical therapy literature regarding pelvic organ prolapse and gynecological surgeries.
And the mission here is crucial.
Yes, our mission today is to connect the dots between your lungs and your pelvis. We're going to prove that your body is a deeply interconnected mechanical system and uncover why fixing a simple cough might actually be the absolute secret to a successful pelvic surgery or, a laxity treatment.
Because the stakes here are incredibly high. I mean, the medical literature shows us that patients are going through major life-altering surgical procedures and then literally unraveling the surgeon's work from the inside out.
Just because they don't understand a cough.
Exactly. Simply because they don't understand the violent physics of a cough. But to understand how that happens, we first have to understand the invisible forces at play inside your torso every single day.
Even when you aren't coughing.
Right.
Okay, so let's unpack this. Because the literature uses this brilliant analogy that, honestly, it completely changed how I visualize the human torso. They call it the soda can anatomy.
I love this one.
It's so good, right? It makes an abstract concept so tangible. Can you explain that for us?
Yeah, so it's the perfect visual for understanding a biological mechanism called intra-abdominal pressure, or IAP. So if you imagine your entire abdominal cavity as a cylindrical container, it basically functions exactly like a sealed soda can.
Okay, so if I'm picturing this can, the top lid sitting right under my ribs would be the diaphragm, right?
Yes, which is the primary muscle we use for breathing.
Got it. And the rounded aluminum sides of the can are made up of the deepest abdominal muscles like the transverse abdominis and the deep spinal muscles wrapping around the back. And then the bottom of the can, the base that holds the whole structure up against gravity, that's the pelvic floor.
That's the pelvic floor.
Yeah.
And in a healthy body, this can doesn't just sit there passively. It actually manages internal pressure dynamically. It operates a lot like a piston in an engine.
Oh, like an up and down motion?
Right. So when you take a breath in, your diaphragm at the top of the can contracts and pushes downward to draw air into your lungs.
Okay.
That downward movement physically decreases the volume inside the abdominal cavity, which, as you'd guess, increases the pressure inside the can.
Because the air has to go somewhere.
Right. That pressure has to go somewhere, so it pushes the pelvic floor down slightly.
And then, I'm guessing, when you exhale, the diaphragm relaxes and lifts back up into the chest cavity.
You got it?
So the internal pressure is relieved, and the pelvic floor just naturally recoils upward. It's like this constant, coordinated up and down dance.
Exactly. And the literature says this happens thousands of times a day without us ever even thinking about it. A healthy, deep core system manages those microfluctuations in pressure seamlessly.
But the mechanism breaks down when the mechanics of the can are compromised by our daily habits.
Yes, poor breathing habits guarantee that this pressure doesn't distribute evenly.
Like chest gripping. The PT literature mentions this, but it didn't fully explain the mechanics of it. What exactly is happening physically when someone is chest gripping?
So chest gripping is when someone breathes really shallowly, primarily high up in their chest and neck, while simultaneously keeping their upper stomach muscles rigidly tight.
Oh, like they're sucking it in.
Yeah, they aren't letting their diaphragm descend fully or their belly expand. So if you go back to the soda can analogy,
Yeah.
chest gripping is like taking your hand and aggressively squeezing the upper third of the aluminum can while you try to pump air into it.
Oh, wow.
Because you are rigidly restricting the top and sides, all that incoming pressure is forced to seek the path of least resistance.
Which is straight down.
Straight down. You are putting constant, localized stress on the lower abdominals and the pelvic floor.
Let's make this real for a second. If you're listening, try it right now. Take a deep breath.
Just a normal breath.
Yeah. Did your shoulders go up toward your ears? Did your stomach stay completely flat or, even suck in? If so, you are chest gripping. You are basically forcing the bottom of your internal soda can to bulge outwards with every single breath you take.
It's a lot of wear and tear.
And then there's breath holding, right? The sources call it the Valsalva maneuver.
Right, the Valsalva maneuver. It's a specific mechanism where you attempt to forcefully exhale against a closed airway. Your vocal cords slam shut, but your abdominal muscles contract violently.
And people do this all the time unconsciously, don't they?
Oh, constantly.
Mhm.
If you hold your breath to lift a heavy box in the garage, or pick up a heavy toddler, or even when you strain on the toilet.
Okay, so mechanically, what's happening to the can?
Mechanically, you are compressing the soda can from the top and the sides simultaneously with maximum force. Doing that once in a while is normal, but relying on that pressure pattern repeatedly, that puts a tremendous mechanical load on the pelvic floor.
Man, so if that is the kind of downward strain we generate just with everyday bad habits, I can only imagine what happens when we introduce a violent, repeated force.
And that brings us to the chronic cough. This is where the soda can undergoes actual structural failure.
Because conditions like asthma, chronic obstructive pulmonary disease, COPD smoker's cough, or even severe seasonal allergies, they aren't just lung issues.
Not at all.
They are creating violent, repeated spikes in that intra-abdominal pressure. It's basically like swinging a wrecking ball at the bottom of the can.
The physiological reality is staggering. A violent cough can force air out of the lungs at speeds approaching 50 to 60 miles per hour.
That is insanely fast.
It is. And to generate that kind of velocity, the abdominal muscles have to contract with incredible suddenness and force. This creates a downward pressure spike that can easily exceed the physical closure force of the urinary sphincter.
Which means the valve just gets blown open.
Exactly. When the downward pressure is greater than the upward closure strength, urine escapes. Clinically, that's stress urinary incontinence.
But the damage goes way beyond just leakage,
It's
right?
beyond.
Because the clinical FAQs from the Women's Health Clinic get really specific about the tissue damage here. They explain that these repeated high-velocity spikes in pressure physically stretch the connective tissues of the pelvic floor over time.
Yes.
So it's not just muscle weakness, it's actual tissue elongation. This can worsen vaginal laxity or drive pelvic organ prolapse.
And for anyone unfamiliar with prolapse, that is the condition where the supportive fascia tears or stretches and organs like the bladder, the uterus, or the rectum literally drop down from their normal position.
Then they bulge into the vaginal canal. Okay, here's where it gets really interesting and honestly a bit counterintuitive. Because if I'm a patient reeling this and I feel laxity or I have a prolapse bulging at the bottom of my internal can, my first logical thought is, well, fix the bottom of the can.
Sure, that makes sense on the surface.
Right. Wouldn't getting a vaginal tightening treatment, like a laser procedure, just reinforce the base and fix the problem?
This raises an important question, and it's perhaps the most common misconception in pelvic health. But the clinical sources are absolutely clear on this mechanism. You cannot out-treat a chronic cough.
But why not? I mean, if the laser stimulates collagen and thickens the tissue, shouldn't that hold the pressure?
Because of the sequencing of care, which is a fundamental rule of these clinical guidelines. Think about the physics of the soda can again.
Okay.
If you have a laser or radiofrequency treatment to tighten the vaginal tissues, you are making the bottom of the can slightly more rigid.
Yeah.
But if you go home and spend the next 3 months violently coughing due to untreated asthma or, a smoking habit.
Those 60-mile-per-hour pressure spikes don't just disappear.
Exactly. They hit that newly tightened tissue over and over again.
You are basically stretching right through whatever thickening the laser just achieved.
You will obliterate the results. The downward force of a chronic cough will always win against the tensile strength of elective tissue tightening.
Wow.
That is why the clinical consensus dictates that elective vaginal tightening or even pelvic floor physiotherapy cannot replace respiratory care.
You have to treat the cough first.
You must treat the cough first. You have to stabilize the pressure inside the system before you spend time and money trying to patch the bottom. You need the asthma inhaler, the allergy medication, or the smoking cessation plan long before you even consult for a laser treatment.
Okay, that makes perfect sense for elective, non-invasive treatments, but let's escalate this.
Let's do it.
What if a patient has a severe prolapse, they ignore their chronic cough, or maybe their surgeon doesn't even ask about their respiratory health, and they proceed straight to major structural surgery?
That is where we see a truly catastrophic phenomenon. It's essentially sabotaging the scalpel.
Yeah, the NHS recovery guidelines and the physical therapy literature provide a really sobering look at this. And just to be clear, I was reading through the names of these procedures, and we are talking about serious reconstructive efforts.
Oh, absolutely.
Things like laparoscopic hysterectomies or colporrhaphies, which, full disclosure, I had to look up.
Yeah, a colporrhaphy is a surgical repair of the vaginal walls. So an anterior colporrhaphy repairs the front wall when the bladder is prolapsing, and a posterior colporrhaphy repairs the back wall when the rectum is pushing through.
Right, and then there's the sacrocolpopexy, which just sounds incredibly intense. The sources describe it as literally using surgical mesh to attach the top of the vagina to the bottom of the spine to hold everything up.
These are major complex surgeries. They involve dissecting tissue, placing deep internal sutures, and anchoring synthetic mesh to bone or strong ligaments.
And the recovery timeline is where the danger truly lies, right? Because patients often develop a false sense of security.
They do. The sources refer to this as the 6-week illusion.
The 6-week illusion.
Yeah. Initial healing, according to the guidelines, takes about 0 to 6 weeks. So after a month and a half, the external incisions on the abdomen or the vaginal opening look completely healed.
So the patient feels pretty good.
They think they are in the clear. But internally, what's actually happening at a cellular level is very different.
What is happening?
Well, internally, you are dealing with fascia and deep connective tissue, not just superficial skin. Fascia has a much lower blood supply than skin or muscle, which means its cellular matrix rebuilds much, much slower.
So it takes longer to heal.
A lot longer. Those delicate tissues and deep sutures take up to 3 full months, sometimes even longer, to truly integrate, scar down, and reach their maximum tensile strength.
3 months. So imagine being in that highly vulnerable 12-week window. Your internal stitches are barely holding the tissue together, and then you get a chest cold or an allergy flare-up, and you introduce a violent asthmatic cough.
You are subjecting fresh internal stitches to severe shearing downward strain. It is comparable to trying to hold wet tissue paper together in a windstorm.
Ouch.
The physical therapy literature makes a fascinating comparison here. Post-op patients are strictly advised to avoid heavy lifting, usually nothing heavier than a full kettle of water for weeks.
Right, I've heard that.
But biomechanically, a violent cough can generate intra-abdominal pressure that rivals or even exceeds the pressure created by deadlifting a heavy weight.
Wait. You're telling me a single violent sneeze or a coughing fit exerts the same internal force as picking up a heavy barbell?
Yes, the internal downward pressure is remarkably similar.
So what does this all mean for the patient? I mean, it means you could go through the anxiety of surgery, the weeks of lost income, the hospital stay, the uncomfortable catheter, only to catch a cold and literally tear the surgeon's work apart from the inside, stitch by stitch.
It's heartbreaking.
Ugh.
And if we connect this to the bigger picture, it fundamentally changes how we view pelvic organ prolapse as a medical community.
How so?
One of the physical therapy sources points out a staggering, almost depressing statistic. Around 5 years post-op, the majority of prolapse repairs will have, quote-unquote, failed in terms of strict anatomical positioning if the top-down pressure isn't addressed.
Let me make sure I'm hearing that correctly. 5 years after major surgery, the organs just fall back down again for the majority of people.
Anatomically, yes, descent often reoccurs. The patient's symptoms might still feel improved compared to before the surgery, but the organs begin to drop again. And the mechanism behind this failure is exactly what we've been discussing.
The pressure.
Right. Prolapse is primarily a top-down pressure problem, not just a bottom-up weakness problem.
Because restoring the anatomy surgically doesn't cure the underlying intra-abdominal pressure dysfunction.
Precisely. If you surgically hoist the organs back up, but the patient goes right back to chest gripping, holding their breath when they lift, straining on the toilet, and chronic coughing, The internal wrecking ball never stops swinging.
It's just a matter of time before it knocks the new surgical scaffolding down again.
Exactly.
That is wild. It completely reframes the body. And it really highlights why the physical therapists in these sources are practically screaming from the rooftops about managing pressure.
They really are.
But let's be realistic here. I mean, we are humans. We catch colds. We get dust in our throats. We can't expect a patient to live in a sterile bubble and never cough again for the rest of their life. So how does someone actually defend their healing body when they feel a cough coming on?
This is where the physical therapy literature really shines, because it moves from doom and gloom to highly specific, actionable defense mechanisms.
Okay, good.
And the absolute most important tool in the arsenal is a technique beautifully named the knack.
The knack. I love that. It sounds like a secret superpower you unlock. What is the mechanism behind it?
Clinically, it's known as functional bracing. The knack is the conscious, deliberate, and rapid contraction of the pelvic floor muscles just before and during a cough, sneeze, or heavy lift.
Oh, it's like playing a game of internal tug-of-war. You basically have to pull the rope before the other side even yanks it.
Yes, exactly.
You are anticipating the massive pressure spike and locking the floor in place so your organs don't get violently pushed down.
It is entirely about timing and muscle fiber recruitment. The NHS Pelvic Floor Center guidelines describe doing fast lifts. You see, our pelvic floor is made up of both slow-twitch muscle fibers, which provide all the endurance, and fast-twitch fibers.
And the fast-twitch ones react instantly to sudden loads.
Exactly. When a cough hits, it happens in milliseconds. Slow-twitch fibers cannot react fast enough. You have to actively engage those fast-twitch fibers right before the cough hits.
So you pull up right before you cough.
You hold that tight contraction through the duration of the cough and then release it. This provides immediate, rigid structural support to the neck of the bladder and the surgical repairs holding the organs.
But the experts in the sources are very careful to note a caveat here, right? Like, the goal isn't just to walk around doing random Kegels all day and keeping your pelvic floor clenched like a fist 24/7.
Oh, no, definitely not. A chronically tight, hypertonic pelvic floor is just as dysfunctional as a weak one.
Right.
Think back to the soda can. If the bottom of the can is made of rigid, unyielding concrete, the pressure still has nowhere to go. It will eventually find a weak point and blow out the sides, perhaps causing an abdominal hernia.
Oh, yikes.
You don't want concrete. You want a dynamic, responsive pelvic floor.
Like a heavy-duty trampoline, it needs to yield slightly to absorb the shock and then bounce right back.
That's the perfect way to look at it. So the knack takes care of the internal bracing, utilizing your own musculature to fight the pressure. But the recovery guides also spend a lot of time on physical, external counterpressure techniques.
Mechanical support from the outside.
Right.
I read this part and thought it was so practical. If you are recovering from a laparoscopic surgery where they've gone in through the abdomen with small incisions, the guidelines advise you to grab a pillow and hug it firmly against your belly when you feel a cough coming on.
It's called splinting the abdomen. By pressing the pillow inward, you are manually resisting the outward and downward expansion of the abdominal wall when the pressure spikes.
And if you've had a vaginal surgery, like the colporrhea pelvic floor repair we talked about earlier, the NHS advises applying manual counterpressure directly to the perineal area.
Right. The perineum is the area of tissue between the vagina and the back passage. If you feel a cough or a sneeze coming on, the protocol is to take your hand or rolled on Powell and press firmly upward against the perineum.
You are literally using your hand as a temporary external pelvic floor.
You are catching the pressure spike from the outside, so your delicate healing internal stitches don't have to bear the full load of the blast.
It's such a vivid visual, but what if the cough is productive? What if you are recovering from surgery, but you also have bronchitis, and there is actual phlegm you need to get out of your chest? You can't just swallow it.
Right, you have to clear it.
The St. Michael's Hospital Guide details an alternative to traditional coughing that honestly blew my mind. They call it huffing.
Huffing is a fantastic mechanical workaround to reduce downward strain. We have to look at the physics of a traditional cough first. A cough is explosive. Your vocal cords slam shut. Your respiratory muscles build up a massive amount of pressurized air behind those closed cords and then forcefully blow them open.
Boom!
Right, boom. That sudden release of trapped high-pressure air is what creates the huge downward spike into the pelvis. Huffing, on the other hand, keeps the glottis open the entire time.
The guide uses a great analogy for this that anyone can picture. It's like you exhale forcefully with your mouth wide open, as if you are trying to breathe on a mirror to clean it.
Yeah, if you try it, you can feel the difference in pressure immediately.
Like a sharp "huh" sound.
Exactly. You do that open mouth huff 2 or 3 times, it utilizes the abdominal muscles to squeeze the air out and move the phlegm higher up the airway. But because the airway is never closed, the air isn't trapped.
Ah.
Therefore, the internal intra-abdominal pressure remains significantly lower.
So you're moving the air fast, but without the explosion.
Exactly. Then, once the huffing has moved the phlegm higher up into the throat, you can do one small, gentle, controlled cough to clear it, rather than 5 explosive, damaging coughs that completely wreck your pelvic floor.
And posture plays a huge role in all of this too, doesn't it? Like the way we sit when we cough.
A massive role. The muscles involved in coughing and the muscles of the pelvic floor work optimally when the spine is in a neutral, straight alignment and you are upright.
So no slouching.
No, if you are slouching on the couch, hunched over your knees while you cough, you are completely compromising the pelvic floor's mechanical advantage. It cannot activate properly to protect the organs when the spine is curved into a C shape.
Wow. So putting it all together, you sit up tall, you pull up the pelvic floor fast to engage the neck, you grab a pillow to splint your abdomen, and you huff the air out instead of barking like a seal. It's an entire choreography of recovery.
It really is. And mastering that choreography shifts the patient from being a passive recipient of a surgery just lying in bed hoping it heals to becoming an active, mechanical defender of their own recovery.
This has been incredibly eye-opening. We started this deep dive wondering if a simple cough could actually derail a complex pelvic treatment. And after looking at the clinical guidelines, the tissue healing timelines, and the sheer physics of intra-abdominal pressure, it's undeniable.
It really is.
Coughing is not just a lung issue. It is a profound, violent mechanical force that echoes through the entire torso. It can stretch out expensive laxity treatments, it can snap internal sutures, and it practically guarantees the failure of a major prolapse repair if it's not managed properly.
It proves beyond a shadow of a doubt that we cannot treat the pelvic floor in isolation.
Right.
I mean, you can have the most skilled, brilliant surgeon in the world, but if they send that patient home with an uncontrolled asthmatic cough and no knowledge of how to physically brace their core, that pristine surgery is fundamentally at risk from the moment they leave the hospital.
Which brings us right back to you listening to this. We want you to physically check in with your own internal soda can today. The next time you lift a heavy bag of groceries out of the trunk of your car or you pick up a child, pay attention to what your core is doing. Are you holding your breath?
Are you clamping down your airway and doing the Valsalva maneuver?
Right.
Notice your baseline breathing right now. Are you chest gripping? Are your shoulders tense, squeezing the top of the can and forcing pressure downward? Or are you allowing your diaphragm to move fully, operating that internal piston system the way evolution designed it?
Because managing that internal pressure isn't just a trick for recovering from surgery, it's the absolute key to protecting your core and your pelvic health for your entire life. It's about preserving the structural integrity of your own anatomy.
The body operates as a closed, interconnected mechanical unit. The pressure created in the chest must always be managed by the pelvis. You cannot separate the two.
Which leaves us with a lingering thought for you to chew on as we wrap up. We started by talking about how modern medicine loves to put the body into isolated, specialized boxes.
Which is true.
You go to a pulmonologist to fix your lungs, you go to a gynecologist or a urologist to fix your pelvis, you treat the plumbing and the ventilation like completely different buildings. But considering how intimately and destructively a simple cough can dismantle a complex pelvic surgery, it makes you wonder.
It really does.
How many other isolated systems in our bodies are actually locked in a hidden, daily mechanical tug-of-war that we are completely ignoring? If the lungs can destroy the pelvis in a matter of milliseconds, what else is pulling on your internal scaffolding right now while you aren't looking?
It's a profound mechanical question. And it's exactly why understanding the physics of your own body is the most powerful preventative tool you will ever have.
We'll leave you with that to ponder. Keep an eye on your soda can, practice your huffing on a mirror, and we will catch you on the next deep dive.